Hello, I'm Charlie Reavis, President, Dysphonia International, and welcome to all of you to a very exciting webinar today. And also, I want to just give a big shout out to all of you on World Voice Day. I know that many of you were able to obtain proclamations from your local governments, state governments, yet other activities to emphasize and make people aware of World Voice Day. So I want to thank all of you for all your work and everything that you're doing for our community. So thank you so much. The webinar today is it's kind of ironic in one way, in that Dr. Young and I were just chatting a few minutes ago that we haven't had too many new things come down the pike, and for those of us living with Spasmodic Dysphonia. So today the webinar is about a study that was conducted by the participants on the webinar on a new botulinum toxin that's called Daxxify. And for most of us, for a long, long time, with our injections, we just simply referred to Botox, and that was the botulinum toxin A that was developed a long time ago by Allergan. So the opportunity to have a new toxin that could, in fact, extend the time frame between injections is very, very exciting. So I'm looking forward to hearing more about the study and more about the details. And also want to report to you, I'm extremely pleased and happy that we were able to provide some funding for this study to help move it forward. Couple of items on basically just housekeeping items. The webinar is being recorded, and it will be available on our YouTube channel and our website, dysphonia.org. And we certainly encourage all of you to submit your questions. But I want to ask you, please put your questions in the Q&A box on your Zoom screen. It's so much easier to monitor and follow the questions in the Q&A box. So if you would do that, thank you so much. We will answer as many questions as time permits. And I want to tell you that if we do not get to all the questions, they will be answered and they will be included as part of the webinar that's posted on our website, again, dysphonia.org. So we're going to start the webinar with Dr. Young, who is a laryngologist and associate professor at University of California, San Francisco. Dr. Young has a wealth of experience in treating various types of voice conditions, and she is also a leader in so many of the laryngology and otolaryngology professional conferences. And I would say that she also does a heck of a lot of educating at a lot of those conferences. So we appreciate all of your work, Dr. Young. So with that, I will turn it over to you.
Thank you. I just want to verify if you can see my screen. We're good? Okay. And if at any point I end up with the dreaded gray box-itis of Zoom, people should let me know. I just want to say thank you for the welcome, and I want to introduce my co-panelist, Dr. Akst, who's a professor at the Johns Hopkins Voice Center from the East Coast. And he and I will be talking about some initial thoughts related to Daxxify. As Charlie mentioned, this is a new option, right? A new formulation of botulinum toxin. I want to start off first with full disclosures that the company that makes the Daxxify, Revance, did provide this material for at least part of this study that we're going to be talking, or the studies, actually plural, that we'll be talking about, and also some partial financial support. Most importantly, I want to say a big thank you to Dysphonia International, always being a great support and a great partner in taking care of patients and working tirelessly for education and advancement of the field and education and patient care. Also, to everyone that's on this webinar, thank you for being here, for being part of this conversation, for being interested. I was able to see as people, thank you for sharing where you're coming from. There are people from all over on this webinar, all across the United States, international attendees, even somebody I saw from the other side of the world. I thank you for spending the time to be here with us. And yes, happy World Voice Day. I'm going to start off with basics. There's going to be a lot I'm about to say. I know that you all know well. I think it's important for us to be level set, right? So we're all starting from the same space. And realistically, we're all starting because everybody here has some connection to a voice issue. It can be shaky. It can be spasmy. It can be squeaky. It's in some way off kilter, whether it's something you experience, something your loved one experiences, something you're taking care of. There are a whole host of different medical conditions that can cause this type of voice condition to occur. Obviously, they're not mutually exclusive. The one that almost everybody is most familiar with, of course, is the one that we've always called spasmodic dysphonia, which is a dystonia that involves the larynx. I know everybody here knows about this. But what you may or may not have heard that in the last few years, there's been a push to call this laryngeal dystonia to better reflect the neurologic nature of this condition. That's why you'll see Dysphonia International, formerly the organization formerly known as the NSDA. Spasmodic dysphonia or laryngeal dystonia comes in a variety of types, the most common of which is adductor type, the ADLD, and that is the focus of the studies that I will be presenting today. So this is specifically related to this subtype. We all know that there are a variety of treatment options for patients that suffer from this voice condition, okay? We're going to focus on what we've all generally and loosely termed Botox, right? What is Botox? Botox has a variety of names, generic names and brand names, but this refers to botulinum toxin A, okay? And what Botox, and I apologize, I should really call it Botox A. I'll slip. Y'all have to forgive me for that. What is it? It's an injected medication, right, that targets the signal coming from the nerve into the muscle, in this case, the vocal cord muscle, that blocks the signals from causing the spasms or the tremor that's resulting in the voice issue. This is a temporary effect, and that's why Botox has to be repeated. I am certain that everybody on this webinar is very familiar with this. So then what's DAXI? DAXI, also known as Daxxify, is a new formulation of this botulinum toxin. It's still an injectable medication, but it is a new formulation that is designed to hang around in the muscle longer. So if it stays there longer, the idea is for the benefit to last longer, for the duration to linger, okay? So it's important to understand you're still looking for the same end result, just maybe a slower rate of it going away, okay? So DAXI in medicine, they started using DAXI, not surprisingly, in cosmetics first. It is FDA approved as of the year before last, predominantly for frown lines and cervical dystonias. There are multiple studies in the scientific literature that shows that DAXI is effective and that DAXI can last longer than standard botulinum toxin A. So the question that came to us in our group here at UCSF Voice and Swallowing Center is, would DAXI last longer than botulinum toxin A in patients with adductor laryngeal dystonia? And this is our group, I have to give a shout out to, who did all the hard work in putting these couple of studies together. So we did this in multiple parts, and I wanted to share with you all about this. So Part one was simply, does DAXI work and is it safe? So we started first with 22 patients with adductor spasmodic dysphonia, and we did a single injection of DAXI instead of the Botox A at approximately the same dose. Okay, our primary outcomes were safety first and foremost, and then also looking at how long the voice benefit lasted for. From a safety perspective, we did start first with a rigorous protocol where for the first 10 patients that ever got DAXI, we did half dose first and then a second injection of the other half, just to make sure that people didn't have any side effects or adverse events. And once we established that it was safe in the first few patients, we were able to move forward with just a single dose, a single injection for subsequent patients. And here are our results. In the first 22 patients that we injected, there were 2 people that had no response at all, and we just assumed that we missed. And anybody that's had Botox knows that sometimes that just happens. So what we really ended up with were 20 patients initially, and compared to Botox A, there were no bad outcomes, no adverse events or complications. There was not any longer period of breathiness than the patients had previously, and they didn't have any more increased risk of swallowing trouble, which we also all know sometimes can happen after Botox injection. All right, but did it work? Yes, all of these patients had improvement of their voice after the DAXI. When we looked at how long the DAXI lasted for, this is a very complex figure that shows sort of how everything shook out for these patients. I'll summarize for you by saying, well, DAXI lasted longer than botulinum toxin A in about 40% of the patients. DAXI lasted for about the same amount of time in 35% of patients. And DAXI was shorter than Botox in about 25% of patients. So realistically speaking, I have to tell you, it was sort of a mixed picture to start. But if you were one of the patients where DAXI actually lasted longer, you got about a 44% longer duration of benefit than you did with your initial Botox A. Okay. Then we asked ourselves, well, is this real? We did it once. Was it just one of those things that happened? Could we reproduce this benefit? And so we always, as always, patients lead this for us. And we did have some patients that chose to go back to botulinum toxin A for a variety of reasons, but we had 13 patients that wanted to keep going with the DAXI. And the next part, phases 2 and 3, will focus on these patients. So phases 2 and 3, we asked ourselves, well, what happens if you do the same dose again? Do you get the same outcome? Or if you increase the dose, do you get a better or different outcome? Okay, so in these 13 patients that had more DAXI, we ended up doing 29 injections. Again, somebody missed, and so we didn't count that one. And so now we're going to talk in this second phase about 28 injection events that occurred. This is an incredibly complex flow sheet where we're trying to show the path that patients took, but I'll summarize for you again. There were 20 repeat same dose injection events that we were able to analyze, and there were 8 events in which we actually increased the dose of the DAXI. And what happened for those in all of these events? I would tell you that once again, we saw that there were no adverse events. We did not see a longer duration of breathy time period. We did not see a higher incidence of people having choking or other swallowing issues afterwards. Did it work? Yep. Still got voice and benefit after DAXI injection. And if the DAXI was helpful, then it lasted 43% longer, about an average of about, DAXI was longer in 43% of patients, and that benefit was about 35% longer than with Botox A. So by the time we finished these multiple phases of study, we didn't have anybody that had a shorter duration of benefit with DAXI compared to Botox. So it was at least the same, possibly better with DAXI. And what this says to us is that we are still in the process of learning about what's the right dosing. Very similar to Botox A, where there's this learning curve with trying to find the right dose in the right space for the right patient. I think this is representative of the process that we're going through with DAXI as well. But encouragingly, if you can get a longer duration of benefit with DAXI, that can mean fewer injections, fewer trips to the clinic, even one less injection a year, which you could conceivably do if you got 30 more days of benefit with DAXI as compared to botulinum toxin A. That could be less hassle, less missed time from work, less cost, less many things. And all of this sounds great. I have to be realistic and acknowledge that there are definitely limitations of the studies that we're presenting here. These are real world designs. So we did this hand in hand with our patients, and a lot of the decision making was jointly made between us and the patients. So it isn't as rigorous as us making a protocol that says you will do this and then you will do that, but we wanted it to be real. Okay. It is a small number of patients to start, and we acknowledge that this definitely needs more people. But it's a start, and at least it's a start that demonstrates enough safety that we feel it's good to continue working on this further. And through the whole study, patients could go back to Botox at any period of time that they wanted to. And we did have some patients that did that. One of key reasons, and I think it's very practically important, is that insurance typically is not paying for DAXI at this point in time. I'm hopeful that that may change in future, but this is the current status. So in conclusion, till now, I would say what we have seen so far is that DAXI is safe. We haven't had any adverse events happening. People are not having longer breathy periods. That's always a major concern among my patients. Actually swallowing sometimes less so. People are like, oh, I just know I need to be careful for X amount of time, but the breathy period really bothers some people. Overall, in our studies so far, we've had about 40% of patients who have a longer benefit with DAXI, and it's about a 33 to 40% longer time period. What does this all mean? I think we still have to keep examining this question. We need to see about changing dosing, increasing dosing, and seeing if we can increase the number of patients that have more benefit. But for us, I would say I think we're very encouraged with what we've seen so far. And so that's where I wanted to pause to thank you all for hearing me out. And I'm keenly interested in hearing what questions that any of you may have. I wanted to start first, though, if I can. I'm going to go to my co-panelists, to Dr. Akst. Dr. Akst, have you had any experience yet with the DAXI yourself?
Great question. Unfortunately, very short answer, which is no, I have not.
Perfect. And that's why I asked you.
But I would love to get some.
Yeah, but that's exactly why I wanted to do this with you, because you, though you haven't used DAXI, I know you have extensive experience with taking care of patients with Botox, with taking care of patients with SD. Sorry, I know I'm supposed to call it LD, and I'm trying. But these patients, you see them, you know this. Tell me your candid first reaction thoughts about these studies. I sent, you've seen the papers, you've read them. What do you think? What's encouraging in that? What's missing in that? What additional questions do you still have? Tell me what you think.
I'm excited is the short version. And I think congratulations, by the way, to you and the entire UCSF team for leading the charge on this. It is a frustrating illness, period. No caveats, no disclaimers. Everyone who's on this call knows it is very frustrating, and it is frustrating because it doesn't always work. When treatment does work, it doesn't last, and you're doing it again, and then again, and then again. So the promise of increased duration, even if it's 40% of folks, is really tremendously meaningful for 40% of folks. I mean, that's, like I said, I'm already excited. Questions that I have, and I realize it's preliminary and it's going to take more study, and many of the people on this call may fortunately get to benefit from this and participate in these studies. But I wonder, longer duration of action. Can we figure out who that 40% is? Right? Is there anything that we can do to predict who's going to be a better DAXI patient, let's say, than a Botox patient? Does longer duration of action have a longer breathy period? I think you've answered that in preliminary fashion, that no, it does not, which is fantastic, because if you think about your numbers, which are referring to duration of voice benefit, that includes a breathy period. So if you actually look at a ratio of good voice to bad voice, and you go from 1 to 2 weeks breathy and 2.5 months, let's say, good in a 3-month injection cycle, to 2 months breathy to 3.5 months in a 4-month injection cycle, you're getting 30 days more benefit, but your ratio of how even more favorable than that. The percent change in that ratio, I think, is going to be higher, and that's wonderful. And then I wonder, does it offer an increased or more narrow, and we don't know yet, and maybe your phase 2 and 3 studies will tell us, therapeutic window. So I have some patients who are exquisitely sensitive to changes in dose, and I wonder if better duration means maybe a little bit more forgiving between that injection left me way too breathy, that injection at what I thought was the exact same dose didn't work at all. Some of it I know is technical, some of it is missing the muscle. But when we hit the muscle, I still find there's cycle-to-cycle variation with Botox. And I wonder if fewer injections or a more stable form or something that binds more tightly is more predictable in its effect. And I don't know if you and the UCSF team have found that cycle by cycle, injection by injection variability, even with, in theory, what is the exact same dose. But that's another source of frustration that DAXI may solve.
Yeah, I will tell you that that was one of the things that we observed, is that cycle to cycle variability that you're describing, that we all know happens clinically. We did see that with the DAXI as well. And given its nature, right, just being a different formulation of botulinum toxin, I guess I should have predicted that. Like, I should have expected that, because that's how Botox behaves, you know? I think that the variability is something that I think frustrates us all. It frustrates me, it frustrates patients. It's a challenge, right? And how can we mitigate that so that it's less variable? I think is an interesting question to ponder for future. Yeah. If you could start using it in your clinic, would you want to?
So the easy answer clinically is yes. The more complicated answer, if you've been looking at the Q&A, relates to, availability, cost, insurance coverage. I'm sure we're going to get to a lot of these issues. So the answer is, would I want to? Yes. And are there barriers? Currently, yes. But hopefully with accumulated experience, those barriers begin to fall.
Yeah. I have not been looking at the Q&A, but I didn't know if our Q&A moderators had seen.
Our fingers are wearing down from trying to answer the questions as much as we can. I would say the biggest question is about payment. So I think it's reasonable to talk about how we do it at UCSF from a payment perspective. It may be different, but at least that's a reasonable place to start.
Mm-hmm. In complete transparency, the initial phases of this study were done as a study protocol. And so the initial parts of the study, the DAXI was provided for people who participated. Ergo, they didn't have to pay for that. And then partway through the study, we ran out of the donated quantities, the supplies. And so we have had some patients that have been straight up willing to pay for it out of pocket. We have had some incidences. We do try to put it through insurance. I will tell you, my experience to date is that insurance has been saying no, generally. I think that honestly, the payment for Botox will be highly variable depending on the hospital, the clinic, the institution, and their policies for that. At my institution, I think I'm allowed to say. When people pay for Botox out of pocket, whether it's for cosmetic or functional purposes, they pay per unit. So it's a multiplier, then that also depends on what is your dose of Botox that you're routinely getting, right? And then translating that to DAXI and then paying some, multiplier per unit of DAXI. I think that our institution set that up like Botox. So if you want DAXI, if your insurance didn't pay for Botox, you'd have to pay for Botox by the unit. And similarly for DAXI, if insurance won't pay for it, then you have to pay for that per unit.
But Dr. Young, I think what I wanted to say is that, or hoping that to get the message out, is that presently insurance companies are paying for the visit and for the procedure itself. And then our patients are paying out of pocket for the medication and
the medication.
Itself. Right.
And worth noting, and we don't need to go too far into it, but for everybody who's participating in this call, it is Byzantine and confusing even to us. But when it does get billed, there's a bill for the injection and a separate bill for the drug, and they are not always covered similarly. So you may have an insurance plan that says, yes, we're going to cover the procedure code, but not the drug because it's not formulary. And I think that's currently where we'd be until there's an accumulated experience that leads the insurance companies to place this on their formulary.
Mm-hmm. Did you all, moderators, want to prioritize or run through some things, or do you want me to just tackle the Q&A? Because I can pull that up also.
There was a question about standard dosing, so you can explain how we dosed everybody.
Oh, yes. So all of the patients, to be included in this study, all the patients had to have a stable Botox dosing for their previous 3. So nobody was like the first time they had an injection, they just jumped straight to DAXI, right? So we needed to know that people would respond to Botox, that they did have a favorable response and a consistent response. So we kept it at the, only people at the same stable dose of Botox that they had. And then we were in communication with the manufacturers, and we used the data that was out there from the previous studies that looked at frown lines and cervical dystonia. In the previous studies that had been done, those studies used a 2-to-1 DAXI to Botox conversion. And so we did the same because that's what they had described. And we communicated with the companies that they said, yes, that's what people in the past have done. And so that's the conversion that we use. So each individual patient got essentially the equivalent dose, that the same level that they had gotten previously, just in a DAXI version instead of a Botox version, because we were hoping that they would respond in the same way as they had in the past. And so for each individual patient, that might be different depending on what their standard Botox dose was. But we didn't give the same dose to everybody, because as we all know, everyone responds differently to different doses. Mm-hmm.
I think it's probably important for us to all acknowledge that this is an off-label use of the medication, and for most likely this will be an off-label use for the medication for a long, long time. Approximately Botox A from Allergan was an off-label use for probably the first 15 years that we were using it for spasmodic dysphonia, laryngeal dystonia, and DAXI will probably be the same.
Mm-hmm.
There's a question about, was breathiness longer in the DAXI patients that had a longer voice benefit, and we did not see that.
Mm-hmm. Other questions? I see a question here about whether patients had unilateral or bilateral injections. I would say, again, I would say that people got the same thing that they've always gotten. whether it was unilateral injection or bilateral. We didn't change.
Keeping this.
We didn't change the practice. Does that make sense? I would say that we tried to be consistent in keeping, or we tried to maintain people's experiences consistently. If they were a unilateral injection of Botox, we continued with unilateral injection of DAXI. And if it was bilateral, it was bilateral. I think that from a clinical perspective, this was the most realistic or real life. I don't know. Dr. Akst, do you often have people that float from unilateral to bilateral, or do they tend to just sort of stay in a pattern?
So it is clearly individualized, but I would say the great majority of my patients receive bilateral injections, and most of them are at somewhat stable dosing, and then there's the depends. But the last couple injections didn't work well. Edge up maybe in dose. I have a big work event coming up next week. I really cannot afford to be breathy. Can we do a little baby injection this time? I realize it won't last as long, but I can't afford the side effects right now, right? But generally, it's bilateral injection, and there are some exceptions to that rule.
Mm-hmm. Mm-hmm. Do you think, I think there are some questions about some of the other subtypes of laryngeal dystonia. Do you think that you would think about this medication any differently in any of the other subtypes? Would you have more concern or less concern, or do you think it might be anticipated to be comparable?
No more concern, anticipated hopefully to be better. So the other subtypes, and maybe somebody who's in the webinar gets Dysport or MyoBlock instead of botulinum toxin type A, Allergan's Botox, right? I rarely use them, and use them only if there's some concern for allergy, for instance, to the particular Botox protein, where it stops being effective because we imagine the immune system's attacking it before it has a chance to make the muscle weak. And those patients might get switched, and that happens fairly infrequently. When it does, there are calculations for dose adjustments, but the thought is that it's still botulinum toxin type A, it's just a slightly different form of it, and that it should last similarly. Same ratio of breathiness to effect, wears off in the same period of time. So DAXI, because it is meant to bind the muscle differently, is meant to last longer. It's not just slightly different and looks different to the immune system, it's meant to behave differently. And to my knowledge, at least, the Dysport, the MyoBlock, and the rest are meant to work the same way. DAXI is meant to work differently.
Mm-hmm. Mm-hmm.
Dr. Young, I think it's probably reasonable. There's a fair number of questions about, will this work for ABSD? And I would say that we didn't include that in the study just because of the lower number of patients eligible to be included in the study, and we wanted to make it as clean as possible. We have used the DAXI for respiratory dystonia in the intraretinoid muscle, and it's worked very well. That paper has already been published, but I would say that if it works for AD, laryngeal dystonia, it will probably work just as well for AB laryngeal dystonia.
I think we would all really hope for that, right? Because the end goal of trying to impact the muscles that are affecting the voice, it's aligned, right? It's still the same end goal. So I would hope it could be just as effective. I mean, we've seen encouraging results so far. Not a home run. I definitely would say that, but I also don't know how much of it is because this is the initial foray into examining this. And I think, as Dr. Akst said so nicely, the variability, it's inherent in the what we're doing and how we're doing it. You can't hit the exact same spot of the muscle every single time you're doing the Botox,
And nor, I'm sorry to interrupt, but nor would you want to. if you've got
Yes,
some Botox
yes.
active in that exact portion, you wish to be maybe a little bit to one side or the other, in theory.
Mm-hmm.
Not to miss the muscle entirely, of course, but to hit a more active part of the muscle that is perhaps not any bit weak, instead of hitting the same exact portion of the muscle, which is perhaps still having some mild persistent weakness.
Yep. Yep. I've seen a number of questions, and I thank Dr. Rosen and the moderators for answering these questions. But I see a lot of questions about, side effects and things like that. And I definitely want to emphasize that the admittedly small number of patients that have participated in this study really didn't have they really didn't have any side effects that they complained about beyond the most common. We focused on the breathiness, the duration of breathiness, and the swallowing troubles, because that's typically what people experience the most often. Do you have a favorite pearl of wisdom, Dr. Akst, for people when they are having, say, dysphagia afterwards, navigating that? Because that can be distressing for people, for sure.
It certainly can be. And I saw some comments about that in the chat, and some people who are currently experiencing dysphagia after a recent injection. So, first, don't be discouraged. It means the Botox is working, right? Let's try to be a little bit optimistic about that dysphagia, and it will get better. Slow, careful sips and time, I saw, were two recommendations. I will tell my patient one way to ensure a slow, careful sip and keep you from gulping is to use a straw, particularly one of those bendy straws, because that keeps your neck in a neutral position and keeps you from, excuse the vernacular, but from chugging, right? Slow, deliberate, one sip at a time. Hopefully you're able to cough less on that. If you're still coughing on a straw, my next step is let's thicken things. Nobody likes to use Thicket, but it exists in the grocery stores and the pharmacies. It's available without a prescription. It is meant to be colorless and odorless and stirred into liquids to make it more of a slurry that's thicker. It's strange drinking thick water. It's strange drinking thick orange juice. But if you need to be drinking something a little bit thicker so it doesn't go down the wrong pipe, Thicket, smoothies, milkshakes are your friend. So consider those if you need to. And then I say, if you're using a straw and you're still coughing and choking, and you're thickening things, you're still coughing and choking, and even the thick and the milkshakes aren't working, please call us, come in, get a modified barium swallow, work with our speech pathologist. Let's work on chin tucks and head turns and whatever strategies we can do to keep you safe. Now, I'm fortunate. Certainly patients come to me complaining of dysphagia. Knock on wood, to my knowledge, I've not had any aspiration pneumonias in 20 years of doing this. So it is distressing to everybody, but if you're slow and you're careful and wait it out, it will get better and hopefully not have any long-term consequence. Mm-hmm. If you are regularly choking on liquids, you should probably take your dose down.
That's the key. Yeah. Lower dose has less risk. I was contemplating when you're talking about thickened water, thickened orange juice. I hear regularly thickened coffee is the worst.
Yeah, I can imagine.
It's just the worst. But I think it's important to keep in mind. But again, it's about trade-offs, right? As with everything related to Botox, and I think DAXI is no different, is you're trying to minimize the duration or frequency of any negative effects, whether it's swallowing trouble or breathiness, while prolonging the good duration of voice for as long as possible, to get you the longest time before it starts to wear off and you have to come back for your next Botox injection. I definitely think that balance, right, is so challenging to address. And that's why there's not one dose that's right for everybody.
Right. And worth stating explicitly that the effects, but also the side effects are flip sides of the same coin. And you can increase dose, but it will increase both effect and side effect. You can decrease dose to decrease side effect, but it will decrease effect. And there's no one way to change dose that gives you more of one without more of the other.
Mm-hmm. Yeah. And that's why I'm excited about the potential for DAXI to increase that, like the balance arm, right? Like that if you can get, even if you had the same degree of or number of days of having a weaker breathy voice or having some difficulty with swallowing, but you could get longer time period before you had to come back again. I still think that's I think that's a beautiful goal. I'd love it to be like a one-time thing that you never have to come back and do ever again. That would be even better. But I don't know. This is the most exciting thing that's come along in the treatment of spasmodic dysphonia in a long time. So I get a little bit excited about that for sure. All right. Other burning questions? Oh, moderator friends.
There's a question about price, and I'd say it's probably too difficult to generalize. At our institution, our hospital is charging approximately $10 per DAXI unit, but I expect it to be different at every place.
Mm-hmm.
There's a fair number of questions about, are we going to continue to do research, or are there any other studies? So presently our study is closed because, as you heard, we exhausted all the funds that were allotted to us, as well as all the DAXI. But I think it's very probable that in the near future we'll have a larger multi-center open label study that will involve multiple different sites, and we can get up to 200 to 300 patients easily. So that will probably be coming in the near future.
Kim, were you saying something? I'm sorry.
There was also a question regarding if somebody stopped responding to Botox, is there any reason to believe that they would respond differently to another version of botulinum toxin A?
That's a really good question.
Lee, what do you think?
And I saw somebody asking that in the chat, and an answer of that's tough to answer in a webinar, because the short version is it depends on why Botox stopped working, right? Mm-hmm. If this is that immune system reaction, which in theory is extraordinarily rare, and the number of patients I've had in these 20 years that have required a switch to a different isoform of botulinum toxin, I could count on one hand or less, right? And typically a decision made by the neurologists who are injecting hundreds of units in arms and legs for things like cerebral palsy, and the laryngeal injections I'm doing are almost incidental to that, or hemifacial spasm or cervical dystonia. So they have had, thousands of units every 3 months, at which point they build antibodies. If that's why Botox isn't working, then sure, this may be a way out of that immune system surveillance, right? If it's not working because maybe the diagnosis needs to be reevaluated. Maybe the laryngeal dystonia has progressed to the point where simply weakening the muscles is not getting the job done because whomever's injecting it misses regularly. DAXI is not magic for any of those things, right? So the answer is find somebody you trust, work the issue. You can test for antibodies by taking a pretty good dose of Botox and inject it right above the eyebrow. You're not going to miss. There's nothing there between skin and skull, but your forehead muscle. And if your eyebrow doesn't get weak, guess what? You probably have antibodies. Switch types of Botox. But otherwise, if the eyebrow gets weak, the Botox is working, then there's something else going on that DAXI might not be a magic bullet for.
Because I do think it's important to remember, it's a different formulation it's still botulinum toxin A, right? It's still a type of Botox. I had a thought. I'm getting to that age of my life where I forgot the thought that was just in my brain. You were talking about location, right? The injection site. I definitely wonder, because DAXI binds better, so it's slower to move and diffuse, which is why it sort of lingers between the nerve and the muscle longer. I do think that I do anticipate that precise localization of where you put it may matter more, right? Or maybe we need to use like a less concentrated quantity of it to allow for some local diffusion in the area. I don't know that we know enough about it yet to know how those like micro adjustments may add, right? May add to or impede the results of any DAXI injections. I think we have to study that more. It's like the very thing that's helping you to get that longer duration may work against you if you don't have it in exactly the most ideal spot. I worry about that. I don't know that we know enough to know, but that's definitely something that I'm keeping in mind based off of what we've learned so far.
Which is an interesting interpretation of the 40% better, 35% the same. Some patients did worse. If the drug chemically is meant to last longer, why is it that there's that slightly unpredictable thing? And it might be that you're right. Everything that it makes the drug, last longer that is in theory beneficial could also make the injection itself technically more challenging.
I was excited that by the time, in the first phase of things, the mixed responses, honestly, I was like, wow, I don't know that I anticipated that. But as with anything with science, when we dug deeper and we take it to the next steps, and we looked further, we were encouraged to see that by the end of our 3 phases of study, we didn't have anybody that ended up like worse off, right? Or that DAXI lasted shorter than Botox. It was at least the same or longer. I think that also speaks to that learning curve that we've been talking about with figuring out how to optimize results.
And speaks to the frustration of patients with this, that even some of those patients who'd had an initially shorter result wanted to try the DAXI again, right? People are hungry for something else that they can do here.
Right. But I also think it's important. Yes, sir.
I'm just going to have a quick question for all 3 of you. Could you guys talk just a couple of minutes about the difference in the compounds, DAXI versus Botox, let's say, that's produced by now AbbVie? But just, kind of generally, what's the difference in the compounding of the drug?
So the simplest way I think I can, that my understanding, I like to keep things very simple, but the botulinum toxin A, the allergen Botox type, right. It has an albumin binding on the Botox material itself. And the Daxxify is a different proprietary, like a peptide. It has a different formulation, it has a different charge, and because it's using a different kind of peptide that attaches to the botulinum toxin, it attaches to the nerve in a different way. It's still ultimately a botulinum toxin A, so it still ultimately does the same thing in terms of the nerve to muscle communication, but the way that it binds and subsequently the way it gets released and processed is slightly different, and that process is why it's proposed to last longer.
Right. Okay. Excellent. Thank you.
Any other burning questions?
I know Dr. Rosen is doing an amazing job answering all these questions in the chat. One of the questions that did come up was dosage comparison. What is the dosing for Botox? How does that compare to the dosing with DAXI?
So I would say that, we are still at an early phase of really fine-tuning our understanding of that. The initial studies that are in the literature related to, glabellar lines and cervical dystonia, they studied it at a 2-to-1 ratio, DAXI to Botox. And that's where we started because that's what's described and out there, and that's our starting point. And when we talked to Reavis, that they said that was, that's what's out there. That's a good starting point. But we all know that there are very important fine-tuned nuances when it comes to using Botox to treat voice conditions. And I think that we started here. I think that our future steps should be to refine that, to figure out, is this 2-to-1 dosing conversion the most accurate? Is it the most appropriate? Is it really reflective of the maximum? Like, is that optimizing what DAXI can do? I think that I think that it's a good starting point, but do we need to study it further to know? I mean, is it 2? Is it 2.2 to 1? Is it 2.5 to 1? Is it something else to 1? Like, is there some other conversion that we need to investigate? I think that needs to be next steps. This is all first steps. These are the first formal studies that I am aware of for DAXI in this setting, and it's just a starting point.
Dr. Young, I
And
just
to
wanna-
complicate it, oh, I'm sorry, please.
I just want to clarify, Revance does not provide any dosing information. We had a verbal confirmation of possible places, and we reviewed the literature, but Revance wanted to make sure it was very clear they are not allowed to give us any information regarding dosing, especially since this is an off-label use. Everything else you said, I totally agree with.
Sorry, I did not mean to misrepresent that.
And I would to complicate it further and say, in the we don't know yet what we don't know, if the ratio overall is 2 to 1, but we look at 40% of patients who got better with DAXI for longer, but some who didn't get better for longer, is the ratio 2.5 in men? Is it 3.2 in women? Is it different if you're over 65, younger than 40? There may be a lot of different variables here that, and I think Dr. Rosen had mentioned this, the possibility of a larger study in multiple sites with hundreds of patients may provide those answers down the road. But we've got to start somewhere, and I'm glad we've started. I'm glad, let me rephrase, I'm glad UCSF has started. I think this is wonderful.
And we, Dysphonia International, are very grateful to Dr. Rosen and Dr. Young because this was an investigator-initiated trial. And so it's just so exciting to be on the edge of this, especially for spasmodic dysphonia. So thank you both for all of that and everyone who supported this trial.
Thank you. I just want to reiterate, thank you all. Thank you at Dysphonia International for supporting us in this work, for supporting our patients with all that you do. Again, thank you to all the participants who are here. This has been an incredible turnout and a lot of interest, and I thank you for spending this time with us. I really do.
Thank you. I want to just reiterate my appreciation from the standpoint of our organization, Dysphonia International, and as a person who has lived with spasmodic dysphonia for 25 years. So for you guys to take on the study, and I know that Clark put a lot of effort in early on in trying to get things initiated and all the discussions, and so just fantastic work. And can't thank all three of you enough. Dr. Akst, appreciate your insight and what you do to help those of us living with dysphonia. So thank all three of you very, very much. We appreciate it.
Thank y'all.
Thank you.
Everyone have a good night.
Thanks. You too.